Good morning, everybody. Thank you for coming out on this very, very hot day. I know it's been a string of very hot weather, and that can be a big challenge. So just wanted to show my appreciation that you all came out for this very important event. As Courtney said, my name is Jenna Neer, and I am your chapter president. I started here 6 months ago in the Mid-America chapter. Before that, I was with the National MS Society up in Minneapolis for 11 and a half years. So I have dedicated a pretty significant portion of my life to multiple sclerosis, and I'm so excited to be here with you today. And this TREND Symposium, this is my very first one, and it's going to be a really fantastic event. I know today you're going to learn, you're going to connect with one another, and you'll have the chance to get inspired because this is some really, really amazing stuff here. So today we're going to look at how far we've come in 30 years. 30 years ago was a really different time. Answers from research seemed far away, and there were fewer resources to manage those day-to-day challenges of MS. Nerve repair couldn't even be imagined 30 years ago. That was like science fiction. And diagnosis of the disease was inconsistent, often inconclusive, and sometimes could take a really long time to validate. What it meant to live with MS was dramatically different 30 years ago, and we have come so far, and you're going to see that today. We have accelerated extraordinary research breakthroughs. So the National MS Society just successfully completed the largest research fundraising campaign that we've ever had, $250 million. And that's a lot of money, yes. I'm very thrilled to announce that. And the funds that were raised in that campaign drove 818 research projects to stop MS in its tracks, restore the damage that's been lost, and find some ways that we can just end this disease forever. Another thing, as the largest national MS society in the world, the one here, right here in the United States, we are leading the International Progressive MS Alliance, which is several MS societies from around the world, some of the brightest researchers from around the globe, trying to find solutions for progressive MS. We don't know all that much about progressive MS when you think about it, and getting us all together in one room, all these great minds, is going to help us get there faster. And actually this year, we identified the first potential treatment option for people living with progressive MS. And so there's some work to be done there, but this is a big deal. And this kind of progress can only be made when we work together on a shared goal. I want to share something else. So right here in our backyard, people are making a really big difference too. We have MS activists who are working together to ensure that the critical research dollars that are allocated in the budget are actually being secured and protected. So how many people in here are MS activists? Maybe you get on the, a bunch of us. And so just last week, this is very timely, and I know Courtney had a lot to do with this, the lovely Courtney who you just heard from. So just last week, congressionally directed MS research ran the risk of getting cut from the federal budget. So thousands of MS activists called their senators, wrote letters, urging their senators to protect this critical funding. And guess what happened? MS activists defeated the Senate amendment that would have eliminated up to $6 million of MS research funding. So again, an example of how we are all working together, and we're stronger when we do that together. So I know you're all here today because you are passionate. You're passionate about creating a world free of MS, raising awareness, and learning and connecting with one another makes us stronger. Later today, when you go home, or later this weekend when you're sharing with your friends and family about the things that you learned here today at the TREND Symposium, you're making our movement even stronger by sharing those things and raising that awareness. Things look much different than they did 30 years ago. Today, people affected by MS are more connected to information, resources, and one another than ever before. The world is a better place for people affected by MS, and it's because of people like you, people like our MS activists, the speakers who you will hear today. It is a better place. But we know there's a lot more to be done. We don't have all the answers, and there is great urgency in this work, and you're going to hear some of that today as well. We need to continue finding solutions for every single person affected by this disease, whether it's someone who's living with the disease themselves or has a loved one living with the disease. We know it affects everybody. And we can't slow down. We have to continue our work to ensure people with MS are more powerful than the challenges of the disease. And we can do this by working together, raising our voices, raising funds, raising awareness. We're going to do this together. And by you being in this room today, that is such a powerful statement that we're all in this together. So thank you again for being here on this very hot day. I'd like to hand it back over, I think, to Courtney to share a few more things to you. And thank you. It's such a pleasure to meet all of you today.
Thanks, Jenna. That was fantastic. Today, it is my pleasure to welcome Dr. Sharon Lynch. Dr. Lynch is a neurologist and professor, as well as the director of the MS Clinic at the University of Kansas Medical Center. She's done extensive research in MS and has served people with MS throughout her career. Her commitment to the MS Society is represented by her service as the chair of the chapter's Healthcare Advisory Committee and a member of the Kansas City Leadership Council. Dr. Lynch was asked to speak today on the progress in MS research because she started practicing as an MS specialist 30 years ago. So along with many of you, she has lived through the progression of MS over that time. Please welcome Dr. Sharon Lynch.
Okay. Can you all hear me? First important thing. So first off, I actually didn't start specializing in MS until about 1988. But I started my residency in neurology in 1984. And so started treating people with MS during my residency program. And so I actually have been involved in treating people with MS for 30 years. And it's been a very interesting 30 years. And I am very thrilled to tell you that as I went through this, I realized just how much stuff we have learned and grown and known about MS since that time. And in fact, we went from no drugs that were expected to alter the progression of the disease to 14, which is pretty amazing. So where were we in 1986? And this was actually a very difficult talk for me to write because I had to keep checking my facts and figure out where we actually were. And there's so much to say that it's sometimes hard to say how are we going to arrange this. So I'm going to tell you what we knew in 5-year increments. And I can't tell you everything we knew even in 86 because we knew too much for me I could have made a lecture in 86 about it, so, you know. But anyway, so in 1986, we made the diagnosis of MS based on a combination of history and physical exam findings. We did not have MRI scans routinely available in 1986. The MRI scan had been developed in 1986, but it was only found as a specialty study in large metropolitan centers. We had other studies that could help, visual evoked responses, spinal fluid. We actually did myelograms and CT scans to rule out other things, and CT scans picked up about 30% of lesions. With modifications, this criteria that was based on a combination of history and physical findings was in effect until 2005 in all clinical trials. In 2001, there was a change in the protocols. And so the Poser criteria, not using an MRI for diagnosis, was actually the way we diagnosed MS until at least 2001. So this is the first ever MRI scan in a human. You can see so much on it, can't you? And that was in 1981. By 1984 or 5, they were much better than this. But they were still, you know, when I look back at the pictures that we thought were really good in 1984 and 85, they were really grainy. And I'm not sure I would have known much about them from that. So the MRI scan in 1986 was first available in 1983, with most large metro cities getting them in the mid-1980s. It had a very low magnet strength. It was not suitable for spinal cord imaging. When they looked at that, if they looked at the patients and they said CDMS, clinically definite MS, 95% of them had a positive MRI. 70% with those that we counted as probable MS had a positive MRI, and 30% with possible MS had a positive MRI. This meant that even then, an MRI scan didn't tell us the whole story. How did we treat it? Well, we used prednisone or ACTH for exacerbations. There was a study published in 1986 suggesting that solumedrol was helpful in MS exacerbations. Cyclophosphamide had been just published as a possibility for very severe multiple sclerosis. That's a chemotherapy drug, if you don't know it, which is fairly commonly used in some cancers even today. And it is something that you certainly can't stay on for long periods of time. Azathioprine, Imuran, was being discussed for MS, and a meta-analysis showed that it might work, and some people began trying to consider using it in relapsing remitting or secondary progressive MS, or progressive MS. And then, of course, we had symptom management. The research studies that I saw listed at that time, and this is certainly not all of them, copolymer 1, now Copaxone, had its first article published in 1987. And by the way, that was a very important article in our research, because it was the first study that actually evaluated the effectiveness of MS drugs by the fact that they had reduced number of relapses in it. Prior to that, it had all been about progression. Every study had been trying to look at progression and whether things change progression. And as we know, chronic progressive MS is harder to evaluate. And so when you try to look at progression over time, it was harder to find a positive study. So the writer of this, Dr. Scheinberg, was the first person who actually said, the way we're going to look at these to see if it works is, are we going to cut down on the number of relapses? And that led the way for us to getting every other drug that we have gotten approved to this day, except mitoxantrone. Other things, cyclosporin A, which was used for transplants, azathioprine, colchicine, which is a drug used for gout, cyclophosphamide, plasmapheresis, hyperbaric oxygen, total lymphoid irradiation, and they began discussing interferons. Gamma interferon was the first one being discussed. In 1986, we also said that MS is mostly a T-cell disease caused by episodes of inflammation. And by the way, the immune system is divided into all different kinds of cells, but the lymphocytes are divided into T and B cells. So the T cells were said to be the most important. The T cells were causing inflammation with selective destruction of the myelin or myelin-producing cells. We didn't know a specific protein involved, thought it was a component of myelin. A few people thought it might be a component of some of the endothelial cells, which are the cells surrounding the blood vessels. We knew that there was some loss of axons in MS. We didn't think it was very important. And we said that this was caused by the axons getting in the way of a specific target of destruction. We thought it was an autoimmune problem, but thought it could be triggered by a virus, and some people thought that it could be a true viral infection. And there were some studies based on the idea of a virus and treating it as a virus. What was the cause of MS? Well, as I said, the viral theory, almost every viral group had been looked at. Leading viral contenders were HTLV1. Remember that HIV, AIDS, was just being identified and discovered at that time, and they were discovering that there were lots of human T lymphocyte viruses or retroviruses. And there was one called HTLV1 that they thought was might have something to do with MS. It does have something to do with a disease that causes what we call a spastic paraparesis. And measles and the Epstein-Barr virus. This HTLV1, there was actually a study published in which they said by PCR techniques, they ran their spinal fluids through a gel, and all of the MS patients were positive and all of the controls were negative. And unfortunately, what happened was they discovered that was because they ran all the MS group together and all the control group together, and there was a lab contaminant. A lot of money was wasted on that, but we did show eventually that it was not the case. We thought there was a genetic predisposition. We thought it was perhaps the HLA system DR2 positivity, and that has continued to be known to this day. That is the only component that has a really strong component in all of genetics, is this HLA DR2, which we've renamed several times, but that was the one. And of course, we knew that there was a north-south gradient, and the age of moving from one place to another made a big difference in whether somebody got MS. So for instance, the farther away you lived from the equator, the more MS was present. And we knew that if somebody was born near the equator and before the age of 15 they moved to the north, they had a higher risk for getting MS. Whereas if they lived at the equator and stayed there till they were in their 20s, then they did not have a high risk of developing MS. So it was where you lived at the time, and the vice versa appeared to be true as well. So they looked at migration studies to point this out. And for symptom management, we had baclofen. It was developed in 1976. We had amantadine and a drug called Cylert, or Pemeline, for fatigue. We used oxybutynin and bethanechol for bladder control. And by the way, this is not an exhaustive list, because if I did that, I would give you a lecture from 1986. Amitriptyline for pain. And exercise was a questionable thing. Some people believed exercise was harmful, and people were advised to not exercise much, and some people were advised to take a nap every day, whether they needed it or not, and some of them were even given Valium to give them a nap, because they were supposed to lay back and kind of relax and not do anything. A good, healthy, balanced diet was considered still a good idea. There was a doctor named Swank who was really hot into a low-fat, low-dairy diet that is still being used by some people today for MS, although it's never been validated. In 1991, we still used the Poser criteria to develop MS, so it's still a clinical diagnosis. And by the way, it is still a clinical diagnosis to this day. It's just that it's been modified to allow the MRI to help us. The MRI had become increasingly important. People were actually looking at it. In 1988, the Fasicus criteria had been established, which are basically rules of looking at an MRI scan and saying, does this pattern of white matter changes in the brain look like MS? But you couldn't see the spinal cord in 1991 worth anything, and so you couldn't really rely on a spinal cord image in 91 to make any kind of recommendations about MS. Treatment. We actually did use Solumedrol in those days, so it was prednisone, Solumedrol, and occasionally ACTH. Some people were treating bad disease with cyclophosphamide. Some people were treating disease with azathioprine, and we still did symptom management. Research studies at that time, they did a gamma interferon study that caused worsening of MS. Beta seron study was ongoing. Copaxone studies were ongoing for aminopyridine. A drug called OKT3 that did not pan out. TGF-beta, which caused worsening of MS. Hyperbaric oxygen, which some people are still trying to tout today, actually had a clinical trial in 1991 that failed. Bee stings. That also failed in the mid-90s. There are still people trying to do that today. Understanding of the pathology. Well, we still believed it was an autoimmune T-cell disease directed against a component of myelin. We believed that the exact component is unknown, and some believe it. This looks like what we believed in 1986, doesn't it? There was some loss of axons in MS. We thought the axons are getting in the way of specific targets of destruction. Again, we think this could be a viral, triggered by a virus, and some people think it could be a viral infection. So this is really not much different. So the viral theory still exists. HTLV1's been disproven. Canine distemper, measles, and Epstein-Barr are still leading contenders. Some suggestion of the chlamydia pneumoniae, which is a small bacterium in the brain. The genetic predisposition theory is stronger. There's a major interest in the T-cell receptor genes, and actually I was one of the people that disproved that one. I was sorry to do that because it was my entire thesis and my entire idea of my fellowship, but in fact it turned out that it was all negative. And there are papers saying it's negative in the literature with my name on them. HLA-DR2 is still a major contender, and what was interesting to me in my research was that I actually saw in my family studies that the DR2 could come from the non-MS side of the family and still be a predictor of MS. So it was actually quite interesting. And people began talking much more about the multifactorial polygenetic theory, which basically was it's not one gene, it's a multitude of genes. And we began developing a lot of interest in environmental factors, including heavy metals, toxins, but none of them seemed to be panning out. Symptom management. Well, we're still using baclofen and diazepam for spasticity. We're still using amantadine and Cylert for fatigue, amitriptyline for pain, oxybutynin and bethanechol for bladder control. And now there are a couple of articles that suggest that exercise might be a good idea and that lack of exercise leads to deconditioning. And then we again began to look at a good, healthy, balanced diet, and there were popular concepts of low fat and high fiber. And people went as far as saying we need a no-fat diet, which I tried to tell them was not a good idea because the brain is about 90% fat. So if you get rid of all the fat, you don't have any fat in the brain either, and that's not a very good idea. In 1996, we continued to use the Poser criteria to diagnose MS, but as MRIs improved, the number of MRI negative patients decreased, and the MRI is considered much more in the diagnosis. Spinal taps become less important, but can be helpful in questionable cases, visually evoked responses for optic nerve abnormalities, and the criteria for subtypes of MS was published by Lublin and Reingold in 1996. And that was important because it separated out the concept of chronic progressive MS from primary to secondary and primary progressive MS, which some of us are going back to again, but that was kind of the law of the land in those days. And this major paper was written in 1996. And by the way, Dr. Reingold had been the vice president in charge of research for the National MS Society for many years. In 1996, we had beta and Seron and Avonex both been approved. Beta Seron in 1993, Avonex in 1996 itself. No other drugs were yet available. Copaxone was sitting at the horizon waiting. We had relapse treatment with solumedrol, prednisone, and rarely ACTH, occasional plasmapheresis. And we had symptom management. Now, in our pathology, we said the same thing about it being a T-cell disease, but we began to realize that axon loss might be a little bit more of an important concept than we thought. The axon, by the way, is when you have a brain cell, the one that actually sends signal from place to place. And the body of that cell sends out a connector to another cell. That's the connection. And that connection is called the axon. And the axon is what's wrapped in myelin. So the concept in the past was that the axon was still good, but the myelin sheath around it was bad. And that's still true in a lot of cases. But unfortunately, what we began to see is how many of those axons were actually gotten rid of in the process. And some people began to develop the theory that maybe the primary target of the disease was not the myelin, but the axon. This was a small group of people who believed that, and some people even believed that the inflammation that we all see and treat was a secondary thing. Again, we believed it was likely an autoimmune problem. Again, triggered by a virus. The evidence for a true viral infection was becoming much less. Research studies in '96, copolymer 1, which is now known as Copaxone, was reported positive, and it was about to come out as the next treatment. Mitoxantrone was being studied. Cladribine was studied in secondary progressive MS and failed. Tumor necrosis factor alpha failed, and 4-aminopyridine was being studied for strengthening. There's a whole lot of other stuff that I'm missing because, again, I would be giving you a lecture about all the research that was going on. There was a ton of it. In 1996, we did continue to look at viruses triggers. Epstein-Barr virus remained in there. Human herpes virus 6 was becoming talked about. Chlamydia pneumoniae thought to be perhaps a secondary problem making MS worse. We had not identified any new candidate genes, and the environmental factors still remained unknown, although we continued to look at environmental toxins. Symptom management had changed a little bit. We had now gotten the baclofen pump for severe spasticity, which is, of course, a major help in people who have severe spasticity and stiffness, and it could be a big life-changing event. Amitriptyline was used for pain, but we also had started using gabapentin and carbamazepine and some other anti-epilepsy drugs. We began trying to use a drug called desmopressin for nighttime control. That was a short-lived thing, and we stopped using it a few years later. Amantadine and Silert still for fatigue. The first paper was published establishing aerobic exercise as a benefit for fatigue and conditioning. That was written by one of my mentors, Dr. Jack Pettijohn. It was really a very important change in our outlook of MS, that we began to see that perhaps it wasn't a good idea to do less, but in fact to begin to do more. And diet, a good, healthy, balanced diet, low fat, high fiber is probably good. In 2001, we established something called the McDonald criteria. So we established a new set of criteria for diagnosis of MS. While we still use the history and exam as important issues, we began formally using the MRI as part of the criteria for diagnosing MS. Spinal taps were considered useful but more limited, and we began to have more experience with the subtypes of MS. MRIs by this time of the cervical and thoracic spine became more useful and could be used to identify lesions of the spine, and that began to be actually something we could use clinically. That was really good because it meant we didn't have to do myelograms to try and keep from getting people with spinal cord disease messed up with MS. Treatment of MS in 2001, beta-seron, Avonex, and Copaxone were well established in the treatment of relapsing remitting MS. Mitoxantrone was approved for rapidly progressive secondary progressive MS. It was limited because of its toxicity to less than 2 years and was, even at that point, fairly toxic. Treatment of relapses had not changed, and we still did symptom management. Research, we did research trials in Copaxone in primary progressive MS. Rebif was about to be released. Natalizumab, which is called Tysabri now, was in study. medication similar to laquinimod, which I've misspelled here, and I can't remember the name of that drug to save my soul. And if any of you remember it, tell me, and I'll put it in the slides. But anyway, there was a heart problem attached to it, and so they withdrew the research. Statin therapy was being looked at as a possible treatment, and mycophenolate mofetil was being studied as an add-on therapy a lot of times, or for progressive MS, and some people still use it for progressive MS today. Understanding of the pathology, well, the first part still hasn't changed, but we continue to realize how big a problem the axons are, and there's really not a lot of change between 2001 and 96. We continue to look at virus as triggers. Major contenders continue to be the Epstein-Barr virus and human herpes virus 6. No new candidate genes have been identified. HLA-DR2, which is now 15, it still remains the major target. Environmental factors remain unknown, still looking at environmental toxins, and now they began to question the possibility of vitamin D. In 2001, the symptom management was pretty much the same for spasticity, but we began using Botox from time to time in local joint problems. We began having Detrol for bladder control. Amantadine and Silert were still used for fatigue. Aerobic exercise was considered a true benefit, and diet was still the same. In 2006, we had new criteria again in 2005, making it permissible to diagnose MS with a little less stringent criteria. The MRI of the C and T spine were well established, and more discussions of the subtypes. Treatment of MS in 2006, we now had the same drugs. Rebif was added from 2001. Natalizumab, or Tysabri, came out briefly in 2005. After PML was found, it was taken off the market, and it was re-established in 2007. So it was off for a little while, and then it went back on in 2007. Mitoxantrone was being used for rapidly progressive toxic MS. Treatment of relapses had not changed, and symptom management continued to be a major issue. So in 2006, natalizumab continued to be in study, likely to return to market. Cladribine in relapsing remitting MS was being studied, teriflunomide, fingolimod, laquinimod, statin therapy, early alemtuzumab, which is now called Lemtrada. It failed in secondary progressive MS in those days. Began doing some work in daclizumab, the phase 1 trials of that, and rituximab, which looked promising in relapsing remitting MS, but failed in primary progressive MS. So our understanding of pathology in MS in 2006 had changed a little bit. Although it doesn't say it in here, we had begun to realize that B cells, yes it does, B cells began to be realized as a major component of MS pathology, and that was really important because some of the drugs we are now beginning to use or study alter the B cells as well. We began to realize how much axonal loss there was, and it was a big concern in the severity of MS. We think it's caused by the axons getting in the way of destruction still. The popular theory of the axons being a primary target is becoming a little more popular. Inflammation is more prominent early in the disease, but we begin to realize how little inflammation is involved in the latter parts of MS, that actually there's a lot less inflammation later in the disease. And many people in this room may know this, but you know, as you get older and you're getting repeat MRIs, that in the beginning the MRIs show a lot of new lesions, a lot of active spots, and as the disease progresses and as you get older, you have fewer and fewer active lesions, fewer and fewer new lesions, even if the person is continuing to worsen. This is likely an autoimmune problem again. possibly triggered by a virus, but very few people now believe that it has anything to do with a direct viral or bacterial infection. And chlamydia and pneumonia had been disproven in the early 2000s. In 2006, we had added a lot more drugs for symptom management, several drugs for bladder control. Cylert had been taken off the market, or practically taken off the market. We began using modafinil, which is also known as Provigil. And the benefit of that was considered somewhat questionable, still is. Aerobic exercise is a benefit for fatigue and conditioning, and again, diet was considered a good, healthy, balanced diet. Probably low fat, high fiber is good. Some more interest in the concept of more fruits and vegetables and a wider variety of diet. 2011, we have yet another diagnostic criterion for MS. And by the way, this is important. You know, people don't think about it, but as we go through and we make it more permissible to diagnose MS with less stringent criteria, that means that the same person would not have been diagnosed with MS earlier as they would now. And so that means sometimes people are diagnosed way earlier in the course. Some people might never, who have a definite diagnosis of MS, might never have developed MS by the older standards. And some would have, but it would have been evident later on. So when we start looking at timelines and history of somebody having MS and how long somebody's had it, sometimes it's important to know what criteria they were using to diagnose it, because where somebody who's older, who was diagnosed in 1985, by the new criteria, had they been perfectly normal, you know, perfectly the same, they might have been diagnosed in 1980 under the new criteria, if we had had our crystal balls and the proper testing. So sometimes when we look at old timelines and new timelines, we can't always make the case that it's the same thing. And one really important thing on that is there's a study that suggested in, you know, the early 90s that the average time to requiring a cane to walk from diagnosis of MS was 14 years. Now we say it's 23. But that 23 may not be quite as long as we think, because it might actually be a few years shorter by the older criteria. So you can't always make all of the assumptions that you think from the studies we know. More discussion of subtypes. What's the difference in subtypes? In 2011, we began to wonder about the muddying of the water between secondary and primary progressive MS. And in 2015, there were yet new criteria for subtypes that were just published that are still in debate. And I'm not going to talk about those because I'm stopping in 2011, and Dr. Belliston here is going to tell us about 2015 and later. Treatment of MS. In 2011, we had finally had the first pill to come out for multiple sclerosis, Gilenya, otherwise known as fingolimod. Tysabri was being used for relapsing MS not responding to first-line drugs. Mitoxantrone was not being used much because we began to realize just how toxic it was, and it can cause long-term heart failure even after the drug was given a long time ago, and it can cause leukemia. So it's not, while I think a lot of people did benefit from it, there are some downsides that are making it much less common for people to use it. Treatment of relapses had not changed, except that ACTH has come back into fashion to some extent. The research being done, Gilenya in primary progressive MS, which failed, Tysabri for secondary progressive MS, which failed, ocrelizumab for relapsing remitting MS and primary progressive MS, and certainly that's still ongoing. Declizumab for relapsing remitting MS, which of course was just approved last week. as the drugs Zenbrita, alemtuzumab for relapsing remitting MS, which was approved in 2014. Teriflunomide for relapsing remitting MS was about to be approved in 2012, and BG12 or Tecfidera for relapsing remitting MS, which also was successful and came to market as Tecfidera. Understanding the pathology, it gets more and more complicated. You can see my slide is getting longer and longer and longer as we get to know more and more and more. And there is now some talk of another type of immunity called innate immunity that may actually have some role to play as well. We begin to, and we still believe there might be some viral triggers, but we really aren't spending a lot of time looking at that, although the Epstein-Barr virus still continues to be a contender. Many new candidate genes have now been discovered, and this was probably one of the biggest changes in the mid to late 2000s, or early, whatever, first decade. Because they began to look at the genes as risk factors with just a small amount of increase per gene. And so they came up with 2 or 3, and then they've come up with now more than 100 different little bitty genes, and none of them, each one of those risks might only increase your risk of having MS by 1%. But when you have 8 or 9 or 10 of those, then your risk gets higher. There's no one gene that seems to be the answer. And still the risk for a first-degree relative, that is a sibling or a brother or a mother, father, daughter, or son, is somewhere around 3%. Smoking is being talked about more and more as a risk. And vitamin D is now strongly believed to be associated with a risk of developing MS, and some people also believe that low vitamin D levels might contribute to relapses. Symptom management, we now have, for spasticity, we actually have Botox, baclofen, tizanidine, and baclofen pumps. In Europe, they have Sativex, which is a derivative of marijuana that is not approved in the United States. And by the way, it appears they can't actually show that it changes the actual stiffness that the person has, but it changes some of the symptoms the person has around it. Amitriptyline is used for pain. We now use gabapentin, Topamax, Lamictal, Cymbalta, carbamazepine, Dilantin, and a host of other drugs. Oxybutynin is used for bladder control, Detrol, Toviaz, Vesicare, and several other new drugs are available. We have been using Ritalin and Dexedrine more also for fatigue, and we have the drug Nuvigil at that point. Ampyra has been approved in 2010 as the walking drug, which is 4-aminopyridine. Remember, we had that all the way through. Aerobic exercise is a benefit for fatigue and conditioning, and some people are talking about yoga. Again, good, healthy, balanced diet, try to reduce processed foods, and the watchword of processed foods was beginning in the early 2000s and has built ever since in the concepts of good dietary practice in MS. There is still no one diet that is recommended in multiple sclerosis. So some things change and some things stay the same. There are major changes in our attitudes about exercise. We are more and more convinced that activity is healthy, and reducing activity can be harmful to someone's health. We have come to have many new drugs. Some have come, and there have been a few that have gone. We've treated relapses the same way for 30 years, and I don't see that changing much. We have learned much more about symptom management. We don't know the causes of MS, but we continue to grow in our knowledge about the details of how all the different factors appear to interact. And we've come to understand a lot more about how a drug for one stage of MS doesn't necessarily help the other stages of the disease. So it's been a really rocky journey for 30 years, and I think you can see how much knowledge we have come to accumulate, so many things that we have come to know about MS, some good and some bad. And we have also encouraged people to become more and more empowered themselves in exercise and diet and trying to make themselves better in addition to the medications that we use. And I think that might be the biggest change. So I'm going to now let my postdoctoral fellow, Dr. Belliston, and I think they want to take a break first. Do you? Okay. Who will talk more about where we are now and where we're going.
I learned a lot. Did you guys learn anything? Yeah, it was fantastic. Thank you so much. There are note cards on your tables. If you have any questions for Dr. Lynch, please write them down. We are going to have Dr. Belliston speak, and then we'll do a question and answer for both of them after he is completed with his presentation as well. It is my pleasure to introduce our next keynote speaker, which is Dr. Scott Belliston. While Dr. Lynch was the perfect presenter to share how far we've come in understanding MS treatments throughout the last 30 years, Dr. Belliston is similarly appropriate to talk about what is on the horizon for MS research. He is completing his first year in a 2-year fellowship with the National Multiple Sclerosis Society as a clinic fellow at the University of Kansas Medical Center under the mentorship of Dr. Lynch. Dr. Belliston attended medical school at Michigan State University's DO program and completed his residency at the University of Kansas. Dr. Belliston recently wrote a Doc Talk article for the MS Connection, which you all should be receiving, and shares his experience growing up with a parent that has MS. Dr. Belliston.
I'm gonna just take a second and switch. I had made some changes to my slides last minute, so I'm gonna pull up the new ones. Okay. Well, good morning. As she said, my name is Scott Belliston, and I am training under Dr. Lynch. I am very pleased this morning to be able to speak to all of you and to be here. I think it was a wonderful review of the past and where we've been by Dr. Lynch. I feel like I have really big shoes to fill following her. Not only am I speaking right after her, but I'm supposed to predict the future. So... looking towards the future of MS, I wanted to talk about kind of this new era that's been brought in the last 5 or 6 years, and Dr. Lynch has started to talk about it, but I think it really started with the introduction of oral medications for MS, starting with Gilenya or fingolimod. That was the first approved FDA medication that was oral for treatment of relapsing remitting MS. And shortly thereafter, we move on to other oral medications, as she mentioned, Aubagio. Did they not come up? Oh. I thought it was not. What did I do? What last time when I... We good now? Okay. So I'll go back, and this is my title page, and then here we have Gilenya, followed by Aubagio. And moving forward, in 2013, we have Tecfidera or dimethyl fumarate, also for relapsing remitting MS. Interesting, Tecfidera was used for some time in Europe for the treatment of psoriasis, and so we'll see as we move forward, a lot of the medications that are coming forward have been used for other treatments of other autoimmune diseases and other things that affect the immune system. And I think that's a part of the future, is looking at medications that we already know about and whether or not they work in MS and whether or not they're safe. And so, and Dr. Lynch had mentioned that about alemtuzumab, or Lemtrada. This has been used for some time in the treatment of leukemia, specifically chronic lymphocytic leukemia. It was known as Campath, and because of its way that it attacks the white blood cells and the way that it works for leukemias, it can be beneficial for aggressive MS, and is now approved for a treatment of MS for those that are not responding to previous medications. And as Dr. Lynch mentioned, just very recently, we have the FDA approval of daclizumab for the treatment of relapsing remitting MS. And daclizumab as well was a medication that had been used for transplant rejection for kidney transplants. And we'll see that, like I mentioned, we continue to look into drugs that are already available to how they may work and help us in MS. So now we have 14 disease-modifying therapies available for the treatment of relapsing remitting MS. So as we talk about the present, I want to discuss what we know about the risk of MS, diagnosis, treatment, and symptom management. So this is not an all-exhaustive list, of course, but I put some of the things that we have had recently, or things that are up and coming. The first one I like to start with is CCSVI. I do this because I found it very intriguing as a medical student. The fact that narrowing of the veins in the neck could be something so simple to cause a disease so complex. And I thought, wow, wouldn't it be wonderful if a procedure could just go in and fix everything? Well, I was very disappointed in 2013 when we did more studies on this, and it was proven that it was not beneficial to go in and open up these blood vessels, and that there was a lot of risk in going through that type of procedure. And I bring it up today because I'm going to talk about technology and how that moves us forward, and how we can use that to benefit us and where we're going with MS. But at times the technology can sometimes hold us back. Just in the last couple months, this theory has hit social media again, very strong, and it's flying all over the internet as a proposed mechanism for treating MS, where we know through a very well-done study that it is actually dangerous. So that's why I bring it up here. We can't always trust everything that's on the internet, but it is something that is very beneficial, and it has helped us in a lot of things moving forward. As far as the environment, we still, as Dr. Lynch mentioned, we think that there are environmental triggers out there, viruses being one of the big ones, smoking as another one that she mentioned. We continue to look for these environmental factors that may be playing a role in putting people at risk for developing MS. Genetics, as she mentioned, is another one that we continue to evaluate and try to understand. We put a lot of efforts into understanding genetic markers and the genetics of MS. Vitamin D deficiency. I find this quite interesting, something, again, that can be very simple over the counter. that can help us. One of the really neat things about vitamin D is we can follow a level. And I see that as a possibility in the future of MS, as being able to follow blood markers of, are we doing what we want to? Are we actually accomplishing what we need to? And this is just a very simple thing, but we can measure what our treatments are doing through a blood test. Obesity has been looked into, not only personal, but maternal. During pregnancy, some feel that maternal obesity can be a risk factor as the vitamin D is sequestered into the fat cells and not in the bloodstream, and that the vitamin D levels being low during pregnancy may have an effect on the fetus. As we move forward, we may see things like including vitamin D in prenatal vitamins. Of course, we're not there yet, but that's something that potentially can be looked into, and making this a less common thing, that less commonly diagnosed. And then, of course, hormones are another very interesting thing. Over the years, there have been times where we've recommended to our patients to not get pregnant, because we knew that after delivery and labor that MS could relapse very bad, and we would tell them to avoid that, to keep their MS from getting worse. Now, as we appreciate a little bit better what the hormones and the immune system are doing during pregnancy, and that the relapse risk is lower for most during their pregnancy, we feel a little bit differently. And in fact, we're even using in some clinical trials estrogen and estrogen derivatives and compounds to see if we can mimic pregnancy as a potential treatment for MS and keeping relapses at bay. And the gut microbiota is probably the one I understand the least, and it's the one that scares me the most. I mean, they talk about millions and millions of bacteria in our intestines that help us digest food, being able to control what disease that we get, not just MS, but other diseases, and being a risk factor. And I think, what kind of symbiotic relationship are we having? And it's quite frightening when we look into it, but it's one of the things that is being looked into, and whether or not changing that microbiota with antibiotics or probiotics can make a difference in someone's MS. As far as diagnosis, Dr. Lynch has talked about the criteria changing and improving our ability to diagnose earlier. However, sometimes that involves people that may not have had a diagnosis before, that may never actually go on to have the type of MS that we would have seen in the past. Of course, MRI, you saw the picture of the first MRI, which you can barely even tell what it is, and you know now that the pictures that we have are quite incredible, the detail that we are able to see of the brain, the way that helps us in our diagnosis. And although we do focus on history and physical exam, it is an excellent tool to help us confirm a diagnosis, and helps people get a diagnosis sooner. And through that, we are using other diagnostic criteria, such as lumbar punctures, less often, which I think is a good thing. And evoked potentials, we rarely see these done anymore. It's a thing of the past almost. And for visual evoked potentials, we now have something that's pretty much taken its place, which is the OCT, or optical coherence tomography, which is an ultrasound of the back of the eye that looks at the thickness of the retina and the optic nerve. And as you can see in this picture here, there's the layers of the optic nerve, and you can look for thinning and for actual what is going on of the nerves of the nervous system as a cause of the MS. And that's really exciting, that we can use that as a diagnostic tool, but also they're starting to use that as tools to monitor our treatment. Is our treatments effective? Are we able to stop the thinning of the optic nerve? And even some studies looking, are we able to regrow or make the optic nerve back to how it was prior to optic neuritis, prior to MS? I'm going to talk about some of the treatments again. I briefly talked about daclizumab, and we'll talk about it again, as well as it's so new. It is the 14th available, approved by the FDA medication for relapsing remitting MS. It's unique. It's a monoclonal antibody against IL-2, which is a signal that's released from the white blood cells that we think is what is causing the white blood cells to go and then attack the central nervous system. So really a different way, as we understand more about MS, the immune system and how it works, how our treatments can be more specific and more directed. However, that being said, it is not a first-line treatment, of course. It does have side effects and things to worry about, so it would be available as a third-line agent. Ocrelizumab, Dr. Lynch had mentioned this being studied in relapsing remitting MS and secondary progressive MS, or primary. Thank you. We'll keep her around. This is a monoclonal antibody that we are seeing more often used in MS that targets the B cells. Dr. Lynch talked a lot about T cells, and over the years, T cells being the target. Rituximab is a medication very similar to ocrelizumab that also targets the B cells, and we think that there may be some relation there, that it's not just a T cell disease, that the B cells are also involved. And learning from that, in our clinical trials, it may show some benefit in progressive MS, particularly certain subtypes, which is exciting to have a drug. I said first here, and I apologize because mitoxantrone would be the first, but another possibility for treating progressive MS. It was granted breakthrough therapy by the FDA, and breakthrough therapy is something that the Food and Drug Administration will do to give priority to a review of a drug that's in clinical trial that shows promise for illnesses that there's currently no treatment for or that are life-threatening. And so they do recognize a need for treatment in progressive MS. Whether or not this will be something that is used, they're recognizing it, and they are trying to give this designation. They're trying to speed the approval process along for these drugs so we can have more to offer to our patients, which I think is really exciting. Other clinical trials that are ongoing in progressive MS that I think are interesting. High-dose biotin. This is vitamin B7, again, another vitamin, something that potentially could be very simple. It is used at much, much higher doses than the recommended daily need or allowance for biotin, and there may be some safety issues with that, and there's things that we'll have to find out through going through clinical trials, but I think it's exciting to look into some of these things. Tiselna is a drug that's in clinical trials for secondary progressive MS, which is also really neat. I think it's a very unique idea where it's a very personalized therapy where taking the blood of a patient of MS, looking at their markers and their immune system, and then targeting the and looking at their immunity to myelin and then targeting that. This was also just finished phase 2 studies and granted a fast track from the FDA as well. So more than one medication being fast tracked and moving forward. Actually, the other one was breakthrough. Fast track is a little different than breakthrough. It's a process to facilitate the development and expedite the review of drugs to treat serious conditions and fill an unmet medical need. And it's important to get new drugs to the patient earlier, and these fast track designations will approach a broad range of serious conditions. Laquinimod, another medication that is being evaluated, not just for relapsing remitting MS, but also primary progressive and secondary progressive, which is exciting. It's an oral medication, which is also exciting. It reduces the white blood cells migration to the central nervous system. Again, kind of using what we know about our immune system and MS to target our therapies. Unfortunately, we had low dose and high dose clinical trials going on, and we found that the higher doses were causing some cardiovascular events and potentially not safe, so that has been suspended. The higher dose, the low dose trial is still ongoing. Ibudilast is another oral medication. This is one that's currently being used as an anti-inflammatory and a drug for neuropathic pain in Japan. I find that really interesting. As they've used it, they feel that it has some neuroprotection or the ability to prevent this damage to the axons that Dr. Lynch was talking about. So we do have ongoing trials for this and secondary progressive and primary progressive MS. And this was another drug that was granted a fast track by the FDA. Anti-LINGO and remyelination. This was a hard thing for me last week. I found that the phase 2 studies did not measure up to what they thought. Anti-LINGO is a drug that is being used to see if it can help with remyelination in MS. However, it did not meet the outcomes, and that was really disappointing to me, and I'm sure as to others. I was debating whether or not to even bring it up, but as I am talking about the future and the present, I felt that it was something to discuss. However, this is something that we're continuing to look into, and there's other things on the horizon, and other medications will come that will have that goal or that target to remyelinate these damaged nerves. As we see, we have more and more treatments available. I think we're getting better at treating the relapses, remitting MS, keeping people from having relapses. However, as we do this, we are seeing more adverse events. We're seeing that not all of our drugs are as safe as we want them to be. We notice that we are dealing with a very delicate balance, our immune system, and with suppressing that there are infections. Dr. Lynch mentioned PML, and we're seeing that in not just one drug, but in many of our drugs as a potential and something that we have to be concerned about. We do feel, however, that we do understand better the risks of PML, that we know what to look for and how to monitor for it, that we can keep people on the drugs that they need to be on as safely as possible. And that's something that is very important, that we measure risk and benefit of our medications, and that we have understanding of what is the risks involved in using them. As far as symptom management, wanted to talk a little bit about Ampyra. Dr. Lynch had mentioned the walking drug, approved in 2010. This is the first medication that has been approved specifically for symptom management in MS, which I think is great. You know, we use many medications to treat different symptoms, but they're not approved directly for treatment in MS. And the way that it works, the way that it helps send these signals from the cells across the axons that are damaged or demyelinated is really a neat concept and something that I hope that we continue to look for other drugs that can help these damaged nerves get the signals to where they need to help mitigate the symptoms of MS. As far as symptom management, one of the things I think we've come a long way in is incontinence, urinary incontinence. Dr. Lynch mentioned Botox for spasticity located to a joint, but we now use Botox in the bladder to help overactive bladders and spastic bladders to help people with their incontinence. I was at a meeting in Maryland 2 weeks ago, and I found out about this pretty cool device called VesiFlow. I'm not sure where we are and using it, but it is available, and I have this video here. I think it's a really interesting concept and something that potentially can give benefit to many of our patients. Let's see. Okay. So I thought that it was really cool. Of course, it's not going to be something widely available to everyone, and of course, not available for men, but something very interesting. And the fact that we're using technology to help with symptoms and to move us forward, I think, is a really cool and important thing as we think about MS and the symptoms of MS. So the future, the part that I dread the most talking to you guys about, what if I don't live up to what the future is, or what if I overshoot what the future has to bring? But I'm going to talk about kind of what that looks like, and some of this is not quite the future. It's already here. Some of it's still the horizon. But I hope to talk about look for more causes of MS, potentially a cure for MS, and even prevention of MS. So as we talk about this, want to talk about technology in medicine and how we're rapidly changing. You can't go to a doctor's office without seeing a computer in each room. And there's a plus and a minus to this. Of course, it helps us keep track of our patients, their medications, and what we're doing, particularly where something as complex as MS, our patients are on multiple medications, and they've been tried on previous medications to keep these things organized and to keep us on top of things. However, they can get in the way. They can be a distraction. So something that I'm constantly thinking about, not letting the computer be a distraction or keep me from actually interacting with the patient. So as we think about this technology pushing us forward, we see that there's apps now available for patients, that they can have medication reminders or track their symptoms or be able to better understand what's going on. I found this really cool. This is a gentleman who's doing physical therapy with electrodes on over his muscles and with a video helping him and guide him and what he's supposed to do and giving him that biofeedback in his therapy as a way to help him. And then, of course, something I think is really cool is these exoskeletons that are being developed and looking at. We have this gentleman here who is in a wheelchair but then able to stand upright. And we do use things like these exoskeletons or standing frames as well to help people that haven't stood for years to be able to shift their weight and be able to take that load in a different way and to feel what that is. Another video I'll just briefly share part of is another cool concept that was developed in one of the VAs, and let's see if I can get it to open. There we go. Just clicking too low. This is a manual wheelchair that someone can use that has hydraulics in it that can take them from sitting to a standing position and then still propel themselves forward manually. And so we'll watch just a little bit of this here, if I can get it to play. Well, so you can see he's in mid-motion there using the hydraulics to get it up, but he's then able to get completely upright from a sitting position, and as he moves upward, the wheels move up with him, the back wheels, and he's able to still use those wheels to propel himself around, be at eye level with those that he's interacting with, and I thought that was a really neat, innovative way to change the way that people are in wheelchairs. So as we look at all these things, the thing in the bladder, the exoskeletons, all these things that are doing things, may feel like our patients are becoming robots. But I think it's interesting. We now have other things that are changing in medicine. We have a thing that's called telemedicine, and through Skype and FaceTime or video conferencing, physicians are able to reach out to rural parts and places that don't have the same healthcare as a big city like we have here. And through these teleconferences, we even have our own physicians becoming more like a robot. While Dr. Lynch does not practice telemedicine, this is something that I do envision for the future. Last night at our graduation for the residents had nominated one of our neurologists as the most likely to be his brain to be frozen cryogenically for the future. And I would think that this actually should go to Dr. Lynch, and preserving her and keeping her moving forward as a robot or whatever way to keep her in practice for patients. So I found this when I was searching through the internet. It's kind of funny. It's like, what is MS? And I think, we think we understand it on many levels, but also it's different for every person. How I describe MS, how my father describes MS, how each of you describe MS is going to be a little bit different. So I think it is a question that we're still trying to figure out. What is MS, and how is it for each person? But moving on from that, what causes MS? This is something that we're constantly trying to figure out. This is something that actually could be possible in the future, that we find the cause of MS, looking at risk factors, environmental exposures, better understanding why the immune system is not functioning correctly, and understanding genetics and doing more gene testing for MS. Just yesterday, there was a new article that came out in Science Advances where they had a large study and they found 4 new genetic markers that they think are a cause or a risk factor for developing MS, bringing the number up to 15 genetic markers that they think are potentially risk factors for MS. So something that's continuing to move forward. This was a study done out of Germany with well over 4,000 MS patients and 10,000 healthy controls. And so they think they're really getting onto some things here. One of the things that unfortunately I think is in our future probably that we still see that the incidence of MS is increasing. And it's more than just us changing our diagnostic criteria and getting better at MS. I think that it's truly more common. Charcot, one of the neurologists who first described MS, he thought MS was more common in men. And in the early 1900s, we see that it's equal men and women. In the 70s, it was twice more common in women than in men, and now 3 times more common in women than men. As we look at this and we try to figure out why that is, there may be clues and keys to better understanding and better treatment. I think going back to the thought of hormones and using those as potential treatments is something that we're going to continue to see in our future and to see as potentials for treatment and management of MS. In the future, I imagine we're going to continue to be able to make the diagnosis sooner in our patients. Many people that, like my father, had to wait over 10 years for a diagnosis of MS. That's not very common anymore. We're diagnosing it a lot sooner. People aren't waiting, wondering what's going on quite as long. I think that it's a possibility in the future that we'll have blood tests to help confirm MS. And that's really exciting and something that will help us along the lines of these genetic markers that are being found. We have other imaging modalities that I expect will be used more commonly in the future. We use some of them in research right now, looking at different biomarkers, glutathione and things through MR spectroscopy, but functional MRIs and even PET scans as a way to maybe understand MS better, diagnose it sooner, or follow our treatments in a way. Thinking of biomarkers and blood tests, we have 14 drugs available, and as I mentioned, they're not all safe for every person, and they do have some side effects. And right now, unfortunately, we do a lot of trial and error. We try to match the drug to the patient based on their symptoms, based on their MS, based on their quality of life and what they want out of a drug. But I imagine in the future something being really amazing is blood markers that help us determine which drugs are going to be more beneficial for a patient, which ones will lead us in the right direction, and maybe take away some of the guessing or the trial and error that we have now. Wanted to talk about recently looked at drug, clemastine. This is an antihistamine that's over the counter. Again, going down the road of taking old drugs and repurposing them in MS. This was recently showed in a very small study of about 20 patients in Southern California to potentially stimulate the repair of myelin along the optic nerves. Why did they choose an old antihistamine that you can't even find over the counter? It's available over the counter, but you go into Walmart, you won't find it usually. In fact, it's used in veterinary medicine more commonly than it is in humans now. It comes down to this PhD, Jonah Chan. I think learning about this man was really quite fascinating, and I think he is a large part of the future of MS, and looking forward to many of the things that we're going to find. He was awarded this prize by the National MS Society for what he's done with clemastine and looking towards myelin repair. Here's what he did is he took what he calls micropillars. They're these cassettes that here we have an image of an electron microscope. This is really magnified, but he has these little pillars that he is able to put the oligodendrocyte cells in vitro, and these micropillars, the oligodendrocytes, are what are responsible for producing myelin in the brain. They're the cells that feed the myelin and produce it. And in a cassette, he's able to test 100 drugs at once on these oligodendrocytes and see which of these medications are beneficial for myelin or harmful to myelin. And through doing this, he's tested over 1,000 medications already, and clemastine looked like the best one for stimulating myelin growth in vitro. So they did a small study in Southern California, and they think that they're seeing benefits from that, and we're going to move on to clinical trials, hopefully here soon, offering that more to our patients. Now, the amount of the drug that they use is much more than what you would get over the counter, and as you know, antihistamines like Benadryl can cause a lot of fatigue. So I'm not recommending that you guys go out and make your fatigue much worse, that we continue to look at these things in a very scientific way, and that we follow the methods of clinical trials that we've done over the years. But really a cool and exciting thing, and I imagine they'll continue looking at many, many more drugs that are already available, that have already been proven safe by the FDA as potentials to treating and potentially repairing myelin. Stem cells. While this is actively being researched, I do see this as a potential future in MS. The National MS Society is currently supporting 12 clinical trials for stem cells in multiple sclerosis. They have supported 68 trials over the last 10 years, so this is something that's not real new, but something that we continue to look into. At this point, we don't have any approved treatments for stem cells. And we have different types of stem cells that we are looking at. So mesenchymal cells are adult stem cells that are present in tissues of the body, particularly the bone marrow, fat, and skin. What they're doing is taking these stem cells from patients and reintroducing them into the central nervous system, either through a lumbar puncture or at different parts of the brain, in hopes that these stem cells, which are cells that have the potential to grow into any type of cell in the body, depending on which nutrients it receives and which signals it receives. So putting them in the central nervous system, the hopes are to regenerate the myelin and areas of damage. And that's being something that's being looked at as a possibility for treating MS and repairing damage. The other is autologous stem cell transplant. And recently there was some interesting and really exciting news on this. So autologous stem cell transplant is something that we do where we give a drug to make the bone marrow that is housing these stem cells release the stem cells out into the blood, so you don't have to get a bone marrow biopsy anymore, which is how they used to harvest these stem cells, but then take them out of the blood and look at them and take the stem cells that they think are beneficial for the immune system and take out the ones that they think are potentially harmful and causing the MS. And at that time, they are giving a very powerful chemotherapy to these patients, essentially annihilating their immune system. Of the 20 patients in Canada that have received this treatment under a clinical trial over the last 13 years, one of the 20 died during this chemotherapy. It's a huge risk. There are infections and things, but it's something that's being looked into and potentially looking to see if there's a safer way of doing this. But knocking out the immune system and then taking those stem cells from these patients and reintroducing them, and with the hopes of rebooting their immune system, making it start over. Now, of the other 19 that they followed, the longest 13 years, some of them just 5 years, not a single one of them has had a new change on their MRI. Not a single one of them have had a new relapse. And I find that to be just amazing. The fact that they can halt the MS in this very small trial shows that we are moving forward, that we are finding new things to use as treatments in MS. And while it's not ready for prime time, and there's going to be many, many more trials that will be ongoing before this is something that's available to the majority of our patients, it is part of our future, something that we're going to see more and more of. So as we look at treatments, I hope in the future that we find treatments that have more benefit and less risk involved, that we can find things that will be more widely available to all of our patients, more affordable medications. Medications right now are incredibly expensive, and I hope that through more generic medications, we have a couple that here very shortly I think will be available as generic, and we do have one generic right now. We'll change this and make these much more affordable and available to our patients, and will change in many ways the future. One thing I've heard and would love would be a vaccination for the JC virus to prevent the possibility of PML, taking that risk out of our minds of the patients that we treat with the different drugs, making that not a worry. That would be incredible. Medications for progressive MS. This is somewhere that in spite of all of our efforts and in spite of many, many trials, we have not been able to really do what we've done in relapsing and remitting MS, but I see that in our future. I see that through many of the things that we talked about today. And of course, medications for remyelination, which I really look forward to seeing more on these. Symptom management. One here, I think we're going to continue to see better medications for symptoms, ones with less side effects, medications for fatigue, not just stimulants, but things that actually address the damaged signals of the damaged nerves, like we see with Ampyra, getting better signal transmission, things that will help with walking, pain, and incontinence. A cure. I really do think this is a possibility. What do we think? What do I mean by a cure? Is it what we're seeing potentially with these stem cells where they're halting? No, I think if we were going to really say that we've cured MS, it will be more than just stopping the progression, but a reversal. We're definitely not there yet. We have a ways to go, quite a ways, but it's something that we continue to strive for. Prevention. This is something that, as we understand the cause of MS, is a potential. You know, if we're able to predict who is at risk, find more biomarkers, find out before they develop it, avoiding environmental triggers, and potentially using medications like vitamin D, melatonin as potentially something that we may see more in the future as things to prevent and maybe keep this from becoming a problem for them. And something that I would love to see would be a vaccination. As we think of viruses as a potential cause, more vaccinations, maybe one that's actually targeted towards those at risk of MS and making them less likely to go on to develop it. This time, I thank you all for your attention, and I guess we're going to turn over some time for some questions. All right.
I'm going to grab this mic here, and you guys can, I'll read the questions, you guys can answer.
No, it's an old drug.
Right, an old.
And I think that it was in a paper that I tried to get from the AAN, but I had to have a password and I couldn't remember what my password was. So I couldn't look it up.
Okay, so the first question I have is, does the early diagnosis help slow the progression?
We hope so. And I think many people believe it might.
Okay. What is the one progressive treatment moving forward? What is the one treatment for progressive MS, is I think how it's supposed to be read, moving forward in 2016? What is the name of that medication?
That's ocrelizumab.
Okay.
And it's going to be questionable how widespread that can be used because it's probably a subset of people that it will benefit.
Can you all hear her okay? Okay, great. Primary progressive has been discussed, but what about secondary progressive MS?
So something I didn't get into, but there is some discussion about whether they are really different or not. And that's part of the new criteria that they're trying to come up with that came out in 2015. Some of the newer drugs looking at progressive MS are not distinguishing between primary and secondary progressive. The ibudilast trial is not distinguishing. The Tysabri trial did distinguish and only used secondary progressives, and of course that did not work. The biotin trial that is coming out, or starting forward, is not going to distinguish between primary and secondary progressive.
Is
I
there
could
any?
get more complicated.
Sure. Sure. Yes, ma'am.
It's not working?
Yeah. So you can see them? Absolutely.
All right, we're going to stand up here.
That way you can see them. Perfect.
Okay, is that better?
Yes.
Okay.
Thank you. Is there any prediction when ocrelizumab may receive FDA approval?
Probably 2017.
This one. So there was a lot of questions about vitamin D, since we're talking about it, and they were all worded a whole lot of ways. One question was, how much should one take? One, does it slow the progression? One was, where should the range be that your vitamin D is in?
Okay, so that's all still in debate, all of that. But basically, one group said that the range should be somewhere between 600 and 4,000 international units a day. Above a level of 50, you begin to get less effect. So somewhere between 30 to 50, 40 to 50, 40 to 55, something like that is probably where you want it to be. If you get too high, you will actually get a reverse effect and you will start getting weaker and feeling worse. And it is not recommended to take more than 4,000 units a day. As far as whether it does affect progression, there's no evidence that it does, but nobody really knows. There is some evidence that is still in debate about whether it reduces the likelihood of an exacerbation. There are some studies that have shown that people who are having a relapse seem to have a low level of vitamin D during the relapse. And that's where the idea that if you keep the level up, you won't have a relapse come from, but nobody knows for sure what that means.
And this one is about stem cell therapy, and they wanted to know how many days or how long the people do the chemotherapy.
It's several weeks of chemotherapy, and it's quite extensive and hard on the body. Because it works to reduce the relapses, it's not considered to be very likely to be beneficial. At least the stem cell transplant type of thing is not considered to be likely to be beneficial to progressive MS. But in the people with really active inflammatory MS with lots of relapses, then it may very well be a benefit.
One thing Dr. Friedman shared with us was the types of chemotherapy that these patients received was not standardized. They were not given a specific medication, but they were given basically a regimen like someone would get for a leukemia, but basically something that would annihilate the immune system. And that was different from patient to patient, but it's usually at least a 21-day process. As I've taken care of leukemia patients, it's a pretty miserable time for them in the hospital at risk of infection.
Okay. Would inflow cause more urinary tract infections?
They are claiming that it causes less. And the idea is getting rid of the stagnant urine and not having that there. Of course, it is a foreign body, and that's why they do recommend changing it every month. And the longer you leave it in, probably the higher risk of it causing a urinary tract infection.
So there's a question about genetics, and it basically asks, what percentage is it likely that your children would have it if you have it and both of your parents have it?
I think in that situation, it's really hard to know because we have so few people like that. These numbers are usually based on one person with MS in the family, which is if you have MS, your children's risk is somewhere between 3 and 5%. But we don't know beyond that.
I guess in identical twins. If you have an identical twin who has MS, the risk is even higher, sharing the exact same DNA. It's probably 20 to 30%.
Dr. Lynch mentioned that as we get older, the MRIs won't show any new or active lesions. At what age does this, or will this occur? Will we stop needing MRIs?
Actually, sometime in the 50s, people stop having as many active lesions.
Optical coherence tomography, otherwise known as an OCT, how are those results versus the appearance of macular degeneration?
So what they're doing is they're looking at a different part of the retina. So when somebody does macular degeneration, they're looking at the part of the retina called the macula. And in the OCT for MS, they're looking at the optic nerve area. So you can't just say the macular, you can't get the same results from the same OCT unless you do the OCT on both areas at the same time.
Okay, this one is about gut bacteria. It says, in our effort to identify and eliminate an offending gut bacteria, do we run risk of getting another disease?
Yeah, actually what is becoming apparent is that the more you have, the better. So I'm glad you asked that question because I knew Dr. Belliston's was not as clear as we could have been on that topic because we don't know as much. But what appears to be is that people who have, let's say, 5 times as many bacteria as someone else are less likely to get MS or to have problems with MS. And when people have a restricted diet, a diet that has fewer and fewer components to it, their gut microbiome becomes more restricted. It has fewer bacteria in it. So people with a high-fat diet that are kind of the meat and potatoes people, you know, they eat meat and potatoes and not much else, the number of bacteria in their gut is much lower than somebody who eats all kinds of different fruits and vegetables and grains and stuff like that. And the people who have this more expansive diet are considered healthier and their gut microbiome is healthier. So you're not actually trying to get rid of a bacteria right now. What you're trying to do is expand the capabilities in the hope that by having so many, if there's one offending one, it gets overwhelmed by the sheer numbers of the others. So eat more dirt.
More dirt. Love it. Okay, so this question is about if someone migrates from an equatorial region to the north prior to 15 years of age, it increases the risk of MS. Does migration back to that region mitigate it?
No, not unless it was before the age of 15. So once they have developed the risk, the higher risk, it doesn't come back. So, no.
Could you explain more about why the equatorial region argument or theory?
Well, you know, this actually came about in the 1950s.
Is it about vitamin D?
60s.
I guess is what I'm asking.
Well, it wasn't originally.
Okay.
This came about as just an observational study in the 1950s, and a lot of it came about from the Jewish migrations, because there were a lot of people with Jewish descent who were migrating to Israel or migrating from the Middle East to the north. And so with all that migration, they did some tracking of patterns on that. And there were some other migration patterns that I was looking at too. But basically, they found that there was this north-south gradient. Now, many people think it might be vitamin D, although there is some discussion about whether the sunlight factor, which is, by the way, sunlight is good in MS, is actually all vitamin D. And there's a lot of theory that perhaps the sunlight, even outside of vitamin D, may have other factors that can be positive in reducing the risk for MS. They did this twin study where they had twins that would tell whether they were in the study, the identical twins, and they looked to see if the twins that were out in the sun more were the ones that were less likely to get MS, and that appeared to be true. So twins who, if there's at a risk for MS, the one that doesn't get out in the sun tends to be the one that gets MS.
And on that, the sunlight, at the CMSC that I went to 2 weeks ago, there's a researcher out of Harvard that thinks that it's actually not vitamin D, but there are other things that we're noticing in conjunction with a low vitamin D level. And that's where he's working on melatonin and our circadian rhythms and the availability of that. So just because we find a low vitamin D level does not necessarily equal the cause, but looking for other things that are associated with decreased sunlight and being indoors.
Okay, this question is about acupuncture or cryotherapy. Do they help the symptoms? Are they good?
I have some people that truly love acupuncture and cryotherapy. I have other people that try it once and say that was the worst thing I ever tried to do. But everybody's different. You know, if for things like pain, if you find something that works, feel free to do it, whether it's massage or acupuncture or standing on your head.
Okay, what is the significance of the shrinking of the cerebellum? Is that the result of myelin damage and therefore subject to today's discussion?
Cerebellum or cerebrum? Probably. Okay. Anyway, there is a shrinkage of the brain in general in people with MS. And I think it is mostly associated with, okay, so the bodies of the cells, remember I told you the cell body sends its axon down to another part and for its connections. And the white matter is mostly the connections. So these cells are really long. So the body might be right up here and it connects way over here, and so that axon goes a long way. And we've discovered that if the axon is transected, sometimes, maybe a long time later, sometimes a short time later, the cell body dies. So first off, a scar itself shrinks. You know how when you have a scar, it seems to be big at first and it shrinks, and that shrinkage down, as it does that, it shrinks the whole area, and so the whole brain, when there's a lot of scars, is going to shrink from those scars. But more importantly, when the cell body dies because its axon died, then the cortex, the part that holds the cell bodies, is always also shrinking.
Okay. If active lesions reduce around age 50, why do you think MS continues to progress?
I kind of just said it.
There you go.
Although that's not all of it, but I think there are other factors that, because there is a toxic, because some of the cells have died, there are toxins that are developing in the system from dead cells, and those toxins cause more cell death. So it's a vicious cycle. We call that oxidative stress.
I think that this question is asking if you are diagnosed with relapsing remitting, are you able to progress to progressive or secondary progressive?
Okay, so secondary progressive means when you used to have relapsing remitting MS, and now and then as you become progressive, as you gradually get worse, that's called secondary progressive. So everyone who's secondary progressive was at one point relapsing remitting. Primary progressive means that you never had a relapse. You just gradually got progressive from the beginning. So that's the difference. So somebody who tells me that they're relapsing, remitting, and asks me if they're ever going to be primary progressive, the answer is no. You might become secondary progressive, but you're not going to become primary progressive, because primary means from the beginning. There is a lot of controversy about this subject, and some people say that everybody with relapsing remitting is going to develop secondary progression. I don't happen to believe that. I've seen too many people that don't. But I think that it's about 50%.
Okay, one last question. It's along those same lines as what we were discussing, that some neurologists argue that there are not subtypes of MS. What are your thoughts on that?
Well, there are subtypes of MS, and everybody with MS is a little bit different. But do we always know exactly what subtype we're dealing with? It's sometimes difficult to say. The newest criteria actually look at the MRI, and what we were talking about with this, the MRI that goes silent, but the patient is getting worse, which is really common in secondary progressive MS. And in primary progressive MS, the MRI doesn't show a lot of active lesions, but the person is getting worse. And you really don't see that activity anymore. And so the newer criteria are looking at that and calling that a different group than the ones who have what we call active MRIs, which are the ones that actually have new and enhancing lesions from time to time. And so someone who is primary progressive but still has active lesions is going to be treated differently and seen differently than somebody who's primary progressive who does not have active lesions.
Yeah, I think that's it.
All right.
Okay, great. Thank you. Thank you to our speakers today. Please look in your packets. There is